Hello and welcome. On behalf of the American Heart Association and Get With The Guidelines programs, I would like to welcome you to today's webinar, Leveraging Get With The Guidelines Data Health Equity. My name is Jessica Wallace, and I am a program consultant for healthcare quality here at the American Heart Association. Before we begin, I'd like to quickly review how to use this webinar platform for today's event. Next slide, please. Next slide, if possible.
Hi, Jessica. Go ahead. It's on the welcome slide.
Yes. Can we move to the next? Oh, it's on the welcome slide?
Yes.
Next slide. Okay. Before we begin, I'd like to quickly review how to use this webinar platform for today's event. On the control panel, when you join today's webinar, you selected to either join by phone or computer audio. If for any reason you would like to change your selection, you can do so by accessing the audio menu in the control panel. You will have the opportunity to submit text questions to today's presenters in the questions section. You may send in your questions at any time, and we'll review the questions during our Q&A at the end of the presentation. Today's slides are available for download in the handout section, and you have access to download them at any time during the presentation. Great. So today we are going to review AHA's vision for health equity. We are also going to talk about Get With The Guidelines programs and health equity, hear from the Joint Commission, and review available resources. All right, so up on the screen right now, this is the American Heart Association's 2024 impact goal, which includes our statements around social determinants of health, structural racism, and rural health. Every person deserves the opportunity for a full and healthy life. Our various departments and divisions are a relentless force to address health equity barriers. And so this this impact goal really served as a call to action for the healthcare quality team. How can our programs and quality consultation with Get With The Guidelines hospitals support this goal? What resources or enhancements can we make to our programs to build and support this goal? And if you're interested to learn more about our program to support rural hospitals, please check out heart.org and then go to professional resources and then the Rural Healthcare Outcomes Accelerator. Next slide. Science-based guidelines are the foundations of our quality programs. And so this presidential advisory, which is a call to action, structural racism is a fundamental driver of health disparities, underscores the importance of health equity into our various hospital quality improvement opportunities. Next slide. Now I'm going to review a few aspects of our quality improvement program. Next slide. So as I mentioned, the various departments and divisions of the American Heart Association all play a part in our drive towards health equity. Fondly known as our PCOP, the image to the right shows our impact areas and reiterates that the heart of our mission is equity. The American Heart Association's quality improvement programs are just a piece of the puzzle to narrow gaps and disparities by converting guidelines into clinical practice to improve patient outcomes. Every patient, every time deserves the right care. Next slide. And so this slide here, just to kind of dive a little bit deeper into our process, wanted to explain how we translate that science into practice. So our AHA experts analyze, discuss, and debate the research. We then issue evidence-based guidelines and recommendations. We try to educate the clinical community on how to adhere to these guidelines. And then we collect the data. So the registry data is entered to measure guideline adherence and is leveraged to improve care delivery. And what we hope is that this improves patient outcomes and leads to longer, healthier lives when guidelines are followed consistently. But what this also shows, this registry data, it can identify any variations in care and identify opportunities for quality improvement efforts to help reduce or eliminate those disparities in care. And then we continue to use Get With The Guidelines data for new research, implementation science, and continued quality improvement. because again, every patient, every time deserves the right care. Next slide. And so here I wanted to highlight one of our evidence-based guidelines. This is the 2021 guideline for the prevention of stroke. And here we have a class 1 or a strong, and then level of evidence COE, which is a consensus of expert opinion based on clinical practice, that specifies in patients with stroke or TIA, evaluating and addressing social determinants of health when managing stroke risk factors is recommended to reduce healthcare disparities. And so this is so important to have this incorporated into the overall guidelines that include what to do with stroke patients as it concerns imaging or medications or education, because we want our clinicians to be thinking about things like medication affordability or housing security when they are treating patients. Next slide. So here's a reminder of our inpatient quality improvement program. So we have programs to help support the care and management of heart failure patients, stroke patients, atrial fibrillation patients, in-hospital resuscitation, and coronary artery disease. Next slide. So what data do we collect? In line with the science in our guidelines, and as we strive toward inclusivity, understanding, and customized care, all Get With the Guideline registries have revised field names and options. And so here you can see the edits we've made to gender and race and ethnicity. And this is, of course, in addition to things like age, zip code, and payer source. As you can see, we added patient gender identity and patient-identified sexual orientation data elements. And these elements aren't required to be abstracted. However, they can greatly increase your overall picture of your patient population, and then you can use that data to inform quality improvement efforts. Next slide. We also added a section about health-related social needs assessments to all registries. And so we know at your hospital or your health system, you may collect this information in various ways, or maybe you don't have an organized way yet of doing this. But we wanted to at least create a framework so that you can start to collect this information and Get With the Guidelines and be able to connect. You know, was there an identified social need of your heart failure patient, for example, and you want to connect that in their Get With the Guidelines case. Next slide. Because once this information is collected, you can then run data and reports to look at your overall patient population. So here is a report that looks at a given hospital for a given time frame, what the identified areas of unmet social need were. And so if you're seeing consistently high percentages of patients with a certain social need, you know, is this something that you can work on internally at your hospital? Are there community organizations you can partner with? But looking at this data is so important to really allow you to see the bigger picture of your patient population. Next slide. Another example of using this data and why to collect it, so you can also use the data to then take a deeper dive into your outcome measures. So this is an outcome measure in heart failure. We look at were discharge appointments made for heart failure patients. And say your hospital, you got your Get With the Guidelines award this year, you're at 85% compliance, you're doing great. But what about that 15%? Is there an opportunity there? Is there a patient population that's not being adequately served at your hospital? And so taking a deeper dive and looking at that outcome measure, filtering it by something like gender identity, and then you're able to see, do we have a gap? And here you can see in this demonstration hospital, there was a gap for patients who identified as genderqueer. And so, okay, what do we do from here? Is there was there a miscommunication? Is there a inavailability of providers? You know, what's going on? How can we better meet the needs of this patient? Next slide. I wanted to give you a brief preview of our new health equity landing page at heart.org. And so here we've kind of compiled a lot of the resources and information I've already shared, and then I'll be sharing some more at the end of the presentation. But wanted to give you a sneak peek of this website and all the wonderful resources it has. Next slide. And so on that website, we link to various organizations because we want to include how this information, how Get With the Guidelines can perhaps support how health equity data collection and Get With the Guidelines can help support requirements from organizations like the Joint Commission or MCQA or HEDIS. We also encourage you to visit CMS's website to understand their framework for health equity. And today we will hear from a representative from the Joint Commission. Next slide. So it is my pleasure to now introduce our speaker for today. Dr. Christina Cordero is a Senior Project Director for Healthcare Standards Development in the Division of Healthcare Quality Evaluation and Improvement at the Joint Commission. Dr. Cordero leads standards development projects for new accreditation and certification requirements and survey processes across multiple settings and programs. She serves as a subject matter expert for several topics, including healthcare equity, antibiotic stewardship, and telehealth. Prior to joining the Joint Commission, she conducted basic science and public health research at Northwestern University's Feinberg School of Medicine. Dr. Cordero earned her doctorate in immunology and microbial pathogenesis and her master's of public health degree from Northwestern University in Chicago, Illinois. So it is now my pleasure to turn today's presentation over to Dr. Cordero.
Thank you so much, Jessica, and thanks everyone for the opportunity to be here today to talk a little bit about the work that we're doing at the Joint Commission around healthcare equity. I think I can advance the slides, but if not, we can just go to the next slide, please. Just to give a little bit of background on me, I've been working at the Joint Commission for about 16 years now, and I have supported our healthcare equity initiative since the first day that I got there. On the next slide, we really consider healthcare equity at the Joint Commission to be a quality and safety priority issue. And so we have tried to include healthcare equity in a number of different standards and initiatives over the years that I'll talk about on the following slides. Just to give you an idea of the way that we've moved this issue forward through different initiatives and kind of how it's evolved with the focus that we've given and the attention that we've put on this issue over the last several years. I don't think I can advance the slide, so if we just go to the next slide. One of the things that we're focused on, again, with healthcare equity being a quality and safety priority, is that we encourage organizations to take a very similar approach to healthcare equity that they do to other patient safety priority issues within their hospitals. And so we want organizations to understand the root causes of healthcare inequities within their patient population, and then to address those inequities with targeted interventions. On the next slide, this connection between equity and quality is not new. This is the cover of Crossing the Quality Chasm back in 2001 from the Institute of Medicine, now the National Academy of Medicine, and they originally identified equity as one of the original 6 domains of quality. And they defined equity as providing care that does not vary in quality because of personal characteristics, such as gender, ethnicity, geographic location, and socioeconomic status. And so this connection has been in place for a number of years, but equity really just hasn't been at the forefront at the way that it is today. On the next slide, this is just an overview of our initiatives over the years. We've been working in the healthcare equity space for a long time. 20 years ago, we started comparing our standards to national recommendations for culturally and linguistic appropriate services, the CLAS standards. We started to look at standards development around patient-provider communication, and this red box towards the right side of the slide just highlights some of the work that we've done in the last year. I think over all this time that I've been with the Joint Commission working on healthcare equity, it's really been remarkable to see the progress that we've been able to make over the years, and particularly in the last 2 years by making this issue really a high priority issue for the Joint Commission and being able to infuse that importance into a number of our different products and services. So today I'll talk a little bit about our new National Patient Safety Goal and then highlight a few components of our new certification program that really move organizations forward on their healthcare equity journey. On the next slide, just to give an overview of that new National Patient Safety Goal. So for those organizations on the call that are accredited by us, you will know that as of July 1st, a couple of weeks ago, we implemented a new National Patient Safety Goal, 160101. That focuses on improving healthcare equity. There are 6 elements of performance or requirements within this National Patient Safety Goal. They'll look very familiar to many of you because these were originally EPs that were in our leadership chapter, and we call it promoted them or elevated them to a National Patient Safety Goal just to continue to increase the priority level around healthcare equity. We have a number of resources that we've put together, a curated collection of resources that our Department of Research has put together on a resource center website to help organizations implement these new requirements. And these requirements are applicable to several different programs within the Joint Commission, our hospitals and critical access hospitals, as well as selected services within our ambulatory program and behavioral health care and human services programs. As I mentioned, we released this National Patient Safety Goal in pre-publication format in January of 2022 to give organizations that 6-month lead-up time to prepare for the implementation, which was just on July 1st. On the next slide, I'll walk through each of the components of this National Patient Safety Goal just to give you an idea of what the overall intent is of these requirements, the types of things that we're looking for on survey, and then I'll highlight a few of the resources that we've put together in our resource center to help organizations with implementation. So this is the content of the NPSG here in this box. It's focused on improving healthcare equity for hospital patients, is making that a quality and safety priority. So the goal of this National Patient Safety Goal, similar to what our goal was back when it was in the leadership chapter, is to highlight the importance of an organization having a commitment and a vision and creativity to be able to commit to healthcare equity at this higher priority level and to continue to make improvements in this area and sustain those improvements. I think a lot of times in the past, organizations may have implemented healthcare equity projects as pilot programs or grant-funded projects that may have made some improvements along the way, but just weren't able to be sustained and maintained in organizations over time. And for us to embed this into a National Patient Safety Goal really highlights the importance of continuing those improvements, again, and sustaining those efforts over the long term. This also includes involving the C-suite of the organization as well as the board in discussions around healthcare equity, again, continuing to elevate the level of importance and include it as a priority issue for the organization overall. The goal of this is to make sure that organizations have established leaders and that they have standardized structures and processes in place to improve healthcare equity. So we'll talk about some of the data collection components as well as some of the dissemination activities around healthcare equity efforts that can really help move an organization forward on this journey. We also, as I mentioned earlier, encourage organizations to fully integrate their efforts around healthcare equity into their existing quality improvement activities. So again, thinking about the structures that you already have in place for other high priority issues and that you can include healthcare equity within those efforts. On the next slide, we'll talk about the first requirement within this standard. This is about designating a leader. So hospitals designate an individual, or it can be multiple individuals, to lead the activities to improve healthcare equity for the hospital's patients. So the idea here is that it establishes clear lines of accountability. You have someone who's accountable for healthcare equity efforts. They can help coordinate those efforts and initiatives across the organization because sometimes those initiatives will include individuals from IT, there may be staff training components, there could be a number of different departments involved, and it's important to have a leader that is accountable for all of the activities that are going on across the organization. This may be someone's designated role and maybe their primary responsibility, or it can be something that's part of a broader set of responsibilities for an individual within your organization. Sometimes questions have come up as well for hospitals that are part of larger healthcare systems. Can this responsibility and this individual be assigned at the corporate level or the system level? And you can do that. And we definitely know organizations have larger efforts going forward system-wide, and so you can have an individual be the leader across an organization, but it's still important to be able to have someone at the different site levels that understands the nuances of those populations or may have slightly different implementation plans at each individual location. So you can have kind of an overall leader at the system level, but then it's also important to have individuals identified at the individual sites that can help move these efforts forward. The other thing that's important to consider here is how your healthcare and equity initiatives are coordinated across the hospital. So again, I mentioned multiple departments may need to come together. Some organizations have put together committees, or they have different offices of healthcare equity and diversity, equity, inclusion, for example, that may be helping to galvanize the efforts around healthcare equity within an organization. On the next slide, this is kind of the first requirement that talks about health-related social needs and collecting data. Jessica talked a little bit about this earlier. So our requirement focuses on hospitals assessing the patient's health-related social needs and then providing information to the patient about community resources and social support services. And so the idea and the intent of this requirement is to assess the health-related social needs of patients within your organization because it can help reduce healthcare disparities and improve health outcomes. I will say there is a lot of flexibility built into this requirement as we're just introducing this, right now as a national patient safety goal as of July 1st. So there's a lot of opportunity here for hospitals to determine the best way to implement this, the best populations to focus on to collect this type of information. And so you don't necessarily need to be collecting health-related social needs for every patient that's in your hospital. We know some organizations are doing that already, and this is part of routine data collection. But we know some organizations will just be starting out on this journey, and these will be new data elements that they'll be implementing. So organizations can identify specific populations or specific areas of their organization where they want to focus this data collection and really start this effort in a specific area of your organization. So we talked a little bit about this earlier, you can focus on heart failure patients. Some organizations are taking this on in their OB population. Some organizations may find that they want to start collecting health-related social needs in the emergency department, for example. So it's really up to your hospital and how you want to focus your data collection efforts and where you want to start. But the idea is that you can then hopefully expand and scale up those efforts to continue to collect this information and expand it to more patient populations going forward. So there's flexibility in terms of which patients are included in the assessment. There's also flexibility in terms of which health-related social needs to assess. So within the full content of this standard in our manual, we have a bulleted list of examples of different health-related social needs that organizations can consider. So you can collect multiple health-related social needs, you can focus on one. It really depends on the population that you're looking at and again, where your organization is on their journey. And then there's also some flexibility here in terms of which resources organizations are providing to patients to address their health-related social needs. So again, some hospitals and healthcare organizations have their own systems in place and initiatives going forward to address health-related social needs. Some will be referring patients to community organizations or social service organizations within the outlying area. And so that, again, is really determined by the population that you want to focus on and how you want to set up that assessment. But the goal of this requirement, again, is to start to collect health-related social needs from a subset of your patient population or your whole patient population and to connect patients with resources to help meet those needs. And so also with here, right now we know some organizations, again, have been doing this for a long time. Some have electronic closed-loop referral systems to provide that information to patients on the nearest food bank to address their food insecurity needs. Other organizations will be providing this information through the patient portal or through discharge instructions. Again, it depends on where your organization is on your healthcare equity journey, but we're just really hoping that organizations can start to collect health-related social needs from patients and start to set up those systems to address those needs. On the next slide, we know that there's always some questions about what should be included in the assessment. Does the Joint Commission have any recommendations for assessments? And so I mentioned that we also, in parallel to developing the standards that I'm talking about today, we also developed a resource center website that has a number of different curated resources that are specific to these different elements of performance that I'm talking about. So we have a when you go onto the resource center, and I have a screenshot of it in a couple of slides, but you can click on a button that just focuses on EP2 and assessing health-related social needs. You click on that button and it will take you to a series of resources that are specific to assessing health-related social needs. And that section has a number of different tools and resources and examples of some of the things that organizations are doing across the country. I've highlighted two here on this slide. The Prepare tool at the top here just has some sample scripting and some information about how to collect this information. And then the tool towards the bottom of the slide here is from CMS that has a couple of pages of assessments on different health-related social needs. So organizations can take a look at some of the questions that are out there, use those as examples, or you can revise those questions to make them more specific to your patient population. One of the things that's also on the Resource Center is our Department of Research put together kind of a question bank type of document where it's a downloadable, it's a PDF document, and they looked at the assessment questions across a number of different tools, and they separated them by health-related social needs. So if you, for example, were looking for example questions on food insecurity, you can take a look at that tool, and it'll show you all the different examples of questions around food insecurity that are embedded in a number of these different tools, so you don't have to download 6 different tools. You can just take a look at that question bank. So we've tried to make it easy and approachable for organizations to figure out how they want to start to include these data elements in their systems. On the next slide, so we're encouraging organizations in EP2 to start to ask patients about the health-related social needs that they're coming into the hospital with. EP3 is more about taking a look at what's happening on the other side. So hospitals identifying healthcare disparities within their patient population by stratifying quality and safety data using the sociodemographic characteristics of their patients. So this is taking a look at your quality and safety data after the fact and trying to look for opportunities to improve the care that you're providing across different strata within your population. So the idea here is to understand which processes and outcomes may vary based on the sociodemographic characteristics that you're collecting. So Jessica talked a little bit earlier about race, ethnicity. Organizations are collecting SOGI data. You can do this by language or location. So a lot of flexibility here in terms of how organizations implement this requirement. Hospitals can choose which measures they want to stratify, again, focusing on the quality and safety metrics that are important to your organization. And then you can also decide which sociodemographic characteristics to use within that stratification analysis. Again, I know that the different organizations are collecting different components of sociodemographic data, so it depends on, again, where you are on your journey, what types of data you have available, and then how you can feed that into this type of stratification analysis to identify gaps in care for specific groups. Some organizations will focus on high-risk topics or select measures that can affect multiple patients. So some organizations, again, will focus on diabetes, for example, or may focus on other measures for specific populations, or some organizations are looking at experience of care measures, or some of the communication metrics that affect all patients. Again, it's really up to the hospital to determine, or the healthcare organization to determine which metrics they want to focus on, and then again, how you want to do that stratification analysis. We did provide some examples of sociodemographic characteristics to use and to consider to include in this type of analysis within the full content of that standard. On the next slide, again, we've got a lot of questions about how are we going to do this? Does the Joint Commission have any recommendations for how to do this type of analysis? And so we have a few resources that I highlighted here, but again, on our Resource Center, if you click on the tab for EP3 around stratification analysis, you'll see a whole host of examples of ways that organizations are stratifying their data around healthcare equity. The few that I've highlighted here are just about having a framework for stratifying race, ethnicity, and language data, if those are the sociodemographic characteristics that you choose to focus on. And then there's also a tool from the Institute for Diversity and Health Equity around health equity, diversity, and inclusion measures for hospitals and health systems. And that has a number of different tools and dashboards that can help organizations get a better picture of the care that they're providing across patient populations, again, hopefully to identify where there may be some gaps and opportunities for improvement. On the next slide, so once you've assessed the patient's health-related social needs and then also looked at your patient population as a whole for potential disparities, the goal of EP4 is to develop an action plan to address those gaps. And so the content here is that the hospital develops a written action plan to describe how it will improve healthcare equity by addressing at least one of the disparities that they've identified. So again, we know some organizations are doing very sophisticated analysis in this area. They may identify multiple disparities that they can address. Our goal with EP4 is just that an organization identifies one disparity that is their priority issue and creates an action plan around that. And so the idea is to focus on one healthcare disparity and to just build an action plan that includes what is your specific population of focus, what is your overall improvement goal, any strategies or resources that you're implementing to reach that goal, and then what's your process to monitor progress. So we want to make sure that you have all of those components so you can see how you're doing after you start to implement your various initiatives. We've had a number of questions as well about action plan examples? Is there a specific template that we require? And again, it really depends on how your organization wants to develop an action plan. We have a couple of examples on the Resource Center, but it's really up to your different healthcare organizations in terms of how you want to structure those plans. And then we'll just be asking questions on survey about what's in your plan, how did you prioritize these issues, and what have you learned so far. On the next slide, so once you have your action plan, we want to make sure it's working. So EP5 is focused on hospitals acting when they are not achieving or sustaining the goals that they've identified in that action plan. So again, we want to make improvements and then also sustain those improvements over time. So the idea here is that we want organizations to assess their progress and then evaluate whether their efforts to reduce healthcare disparities are successful. Are there opportunities to increase training in a certain area, or do you need more IT resources to help with data collection in another area? The idea is to just identify if there's areas where your action plan is not as effective as it can be, and what can the organization do to continue to make improvements in this area. So there's a number of different ways. Again, organizations can do this. We're not overly prescriptive on how these revisions are made, but organizations can go back to their stratification analysis. So say you do that stratification analysis I talked about in element of performance 3, you identify a disparity, you implement an intervention, and then you go back to that quality and safety metric and run that stratification analysis again to see if you're closing that gap. Some organizations may do something around interpreting services, for example. And so maybe they implemented a new language service for a new language and a new population that they're seeing, and you can collect feedback from patients about that service or other opportunities to improve. Do you need additional interpreters in a certain area or additional interpreters in a certain language? There may be some organizations that will look at staff training or education needs, and that may help them identify areas to revise their action plan. One of the things that we've heard so far is some organizations are starting to collect more sociodemographic data around race and ethnicity, for example, trying to get some more details around granular ethnicity categories, and maybe they find that they need some additional staff training to help ask those questions in a sensitive manner or to explain why your organization is collecting that information to patients so that you can get some more accurate information into your process. On the next slide, so we're making improvements, and then the last requirement here is just to make sure that everyone within your organization is informed about what you're doing. And so at least annually, we are expecting organizations to inform key internal stakeholders, including their leaders, licensed practitioners, and staff, about the progress that they're making around healthcare equity. So you want to make sure that organizationally, folks across the organization are aware of what your organization's initiatives are to improve healthcare equity, what populations you may be focusing on, and what their potential role may be in those activities. And so, again, a lot of flexibility here in terms of how organizations disseminate that information to their staff. It can be through presentations, newsletters, quarterly meetings. Some organizations are using progress boards, intranet pages. Again, they may be driving it through their Office of Health Equity, so maybe there's a separate landing page for that or a seminar series. It's really up to your organization, how it's structured, how you're providing information and updates to individuals across the organization. On the next slide, just a quick screenshot here. I think this is the Resource Center I mentioned earlier. This is what it looks like. So this is the website address here, and as I mentioned, if you're interested in resources that are specific to one of the requirements that I've talked about, you can go directly to the box that says, action plan, and you can click on that, and it'll take you directly to resources that are specific to action plans. We also have a series of snapshots and sound bites on our website as well, in addition to these different strategies for implementation. We had an opportunity to go to a number of leading organizations across the country, interview staff, hear a little bit more about the challenges and barriers they've encountered around these different topics in healthcare equity, and there's a lot of videos as well as two-page sort of downloadable case studies that you can take a look at as well to learn a bit from other organizations that are excelling in this area. On the next slide. Just to talk a little bit about the new Healthcare Equity Certification Program that we also launched July 1. So we've had a very busy summer. So we have our accreditation requirements that I just spoke about, and then we also have launched a freestanding certification program that's focused on healthcare equity. And so the certification program recognizes organizations that are going above and beyond what we're requiring for accreditation and really striving for excellence in this area. And so this is a voluntary program specific for hospitals right now. separate from the accreditation process that focuses on healthcare equity and, again, kind of moves the field a little bit more forward. Kind of is it a lot of the requirements within our certification program are a natural extension of our expectations on the accreditation side. Just continues to move the field one more step forward. So as I mentioned, they build upon the long-standing requirements that we've had around healthcare equity in our manuals for years, as well as the new national patient safety goal that we just talked about. And then our plan is to start accepting applications. We've already started accepting applications a couple of weeks ago. On the next slide, just to give you a general idea, I won't go through all the requirements in the certification program, but just to let you know, it came out a little bit small, so when you get the download of the slides, I'll see if I can update this, because even I can't read that. But just to give you an idea that there's 5 chapters within the program, 5 domains that we're trying to address. Leadership has requirements, again, that talk about not just making healthcare equity a priority, but really involving leadership across the organization, as well as including the board in your strategic plan specific to healthcare equity. So again, trying to continue to elevate this as a priority issue and embed it within an organization's strategic plan, within their budget. So there's some requirements around that. We have a section on collaboration that would require organizations to have processes in place to collaborate with patients and family members and caregivers to identify patient-level needs within an organization. And there's also an expectation to collaborate with the community to identify community-level needs and other areas that an organization may need to address for, again, the larger community that they serve. There's a whole section on data collection, again, expanding on some of the comments and the requirements that we just talked about. There's a requirement around looking at community-level data. There's a whole host of requirements around collecting self-reported patient-level data, a little bit more specificity around health-related social needs, a little bit more expectation around collecting this type of information from all patients versus a subset or a focus group, which we talked about for the National Patient Safety Goal. And then there's also a new component here about collecting data around self-reported data around race, ethnicity, and languages spoken from the staff. And so there's a goal here of trying to increase language concordance or racial and ethnic concordance between staff and patient population. There's a chapter on provision of care that really makes use of the data elements that we're asking organizations to collect to improve the provision of care for all patients. There's a little bit in there about workforce diversity. There's some components around staff training and making sure that individuals understand why the organization is taking on healthcare equity as such a high priority issue and what their goals are. And then there's some information around qualifications for language interpreters, patients with disabilities, and some specific components around meeting the needs of that population, and then a little bit more about making sure that you're using the information around a patient's health-related social needs as you plan for their care. And then there is a whole section on performance improvement. There's a chapter here about using the different data elements that you're collecting and trying to understand opportunities to improve your services and improve healthcare equity for the patient population. And then the other half of that chapter is focused on using data around staff and trying to improve diversity, equity, and inclusion initiatives internally. On the next slide, I think that might be my last one here. I think this is just a screenshot. This is the screenshot of our landing page for the new certification program and the website. If you're interested, you can take a look at the requirements themselves as well as the resource center. And then we also have an on-demand webinar that we just posted that walks you through the requirements within the certification program, very similar to what we just did with the National Patient Safety Goal. So with that, I will turn it back over to Jessica, and then I think we'd take questions at the end.
Great, thank you so much. Yes, so if you have any questions, please submit them via text in the question section of your control panel. All right, so if we want to keep you excited about collecting this data, right? We want to give you additional examples of why you should be excited and why you should consider collecting this health equity information. So next slide. So just an example of what others have started to use Get With the Guidelines data for. So really, just to underscore, we're trying to study patient risk factors, your hospital characteristics, temporal trends, geographic differences, things like that. We want you to be able to link to other databases like CMS, and really look at your data from a health equity lens. How can you better serve your patient population? There's also considerations around community, pre-hospital, and hospital-level policies that you may want to look at from a health equity lens as well. Next slide. And so some researchers and clinicians have already started asking these questions and using their Get With the Guidelines data to inform those questions. So on heart.org, when you look for our Get With the Guidelines research publication, you can now filter by health equity publications. So here's just a few examples here. One looked at the influence of social determinants of health on heart failure patients. One looked at racial disparities in refusal of stroke thrombolysis in Chicago, and then some other quality of care outcome-related things based on race, ethnicity. Next slide. And so if you want to use your Get With the Guidelines data for research, we encourage you to do so. This slide just shows you a brief snapshot of our policy, and the research department info is above. Our policies can be found at the website listed on this slide, or you can always reach out to your Get With the Guidelines quality improvement manager as well for more information. Next slide. I wanted to also highlight we have a nursing-led abstract competition going on right now. I know there's probably a lot of nurses on the line right now, so if you have a great idea for a research abstract that uses your hospital or health system's Get With the Guidelines data, we're asking you to submit it by the end of August this year. And reminder that these topics can cover stroke care with various topics. So continuum of care, process improvement, implementation, or intervention. Abstract submissions are not required to have data or be a fully formed proposal. Again, we're just looking for that abstract idea, and we will pay special attention to social determinant of health topics. Next slide. All right, so once again, on that health equity landing page that you can find from heart.org, we have a couple additional resources. So we kind of summarize how you can collect the data, why you should collect the data, and then some guides on how to run reports. So earlier in the presentation, I kind of went through what data is possible to be collected. I hope throughout this presentation, you've kind of started to think about why it's important, and then we have some guides too on how to continue to use that data. Next slide. All right, so we'll leave this quote up for now. And thank you so much to Dr. Cordero for presenting. And I'm now going to turn it over to our moderator for our Q&A, Renee Sednews, the Senior Manager.
Thank you, Jessica, and thanks to everybody for submitting your questions. And as a reminder, you can continue submitting the text questions using your dashboard. Everybody is in listen only, so you won't be able to come off mute, but we'll keep an eye on those questions coming in. First, Dr. Cordero, there's a couple specific questions about, the Joint Commission requirements, and especially in the context of stroke certification. So the question today is, given that the Joint Commission requirements on health equity are specific to the hospital and system, how will this translate into certified program surveys by the Joint Commission, such as for primary stroke center or comprehensive stroke center recertification?
I think I may need to circle back on some of the details there, but I'll say right now, the healthcare equity certification is separate from our other certification programs. What I think we've started to do is, as new programs have been in development, the perinatal program is a great example. As that program was starting to be developed at the same time as we were doing this program for healthcare equity, you'll see some of the elements of healthcare equity start to be embedded within the certification requirements in that perinatal program. So I don't know in the future if we'll start to move some of these requirements over into some of our other existing programs around primary stroke, for example, or some of our other programs. We'll start to see inclusion of some of these elements. I'm not quite sure, and I can again circle back with the team over at the Joint Commission to see if there's any plans for as we update other programs if we'll start to infuse some of these components into them. But I know with new development with other certification programs that we're doing, we have started to move some of the elements in there where they make sense, just to continue to encourage organizations to look at healthcare equity across all of our different programs. But right now, we haven't done an update recently, so I don't think that or at least we didn't include new requirements within those programs around healthcare equity, but I'm not quite sure what the plan is going forward.
Thank you. So in your work, developing this criteria, these requirements, what are some barriers that you have found that hospitals have encountered, or that you expect hospitals may encounter from collecting the data elements and coming up with the resources and being able to share those with patients? And kind of the second part to that question, how do you think that what are some strategies for overcoming those barriers?
Sure. Well, I think one of the things that we've seen, I talked about we just implemented the National Patient Safety Goal, but 6 months ago it was in our leadership chapter. So we've already started to get questions from organizations that were preparing for survey at the beginning part of the year. We started to get some input from our surveyors on survey in the beginning part of the year, just to see where the challenges may be for organizations, just to start to address these healthcare equity elements. And I think data collection is a huge component there. I think organizations may have already been collecting. We've had a requirement in our accreditation manuals to collect race and ethnicity for years. And I think organizations were thinking, okay, we've been collecting this for a long time. We should be able to access that information, stratify these different measures, and then when they were preparing for survey, they realized that maybe there's some glitches in that process, or they need additional data collection support and, again, scripting, some explanation to patients, or just they're not collecting an accurate, their information is not as accurate as they had hoped it would be, or it's not as accessible as they hoped it would be. They were collecting it, but not with the idea that they would use it for stratification in the future. So I think those are probably some of the early kind of pain points that organizations are seeing, is where they're understanding that they need to, before they can do an action plan to address disparities, they're realizing that they need to go back and look at their data collection process again to make sure that it's set up to prepare them to do kind of this back-end analysis that we're looking for within the accreditation requirements, as well as, again, there's other leading organizations across the country. CMS is asking for some attestation of different data components as well. So I think as organizations have started to prepare for these new requirements from us as well as other organizations, they're starting to see some opportunities to improve some fundamental components of their process, let alone taking that data to use it for disparities work.
That's great, thank you. And I know in the slides that are available to everybody in the handout section, you have some great resources in there, some toolkits on preparing for this certification. There's a question about generally how long does it take to prepare before applying for certification?
Right now, I think the way we have it on our website, it can take between 4 and 6 months for organizations to just prepare for the process for the operational components. But I think it really depends on where an organization is in terms of addressing the different requirements that we have, and really how much they've already put forward around healthcare equity, and then the structures to collect that type of information, the different data components that we're asking for all patients versus a subset of patients, which again, on the accreditation side, that addresses organizations that may be starting out in this area. Certification really is to highlight organizations that have been doing this for a long time. So again, if you have these structures in place to collect self-reported patient-level data on race, ethnicity, on language, disability, then organizations would be well-suited to apply for certification earlier. But I think that setting up the structures to collect that type of information and do staff training around some of these issues may be some newer components to some individuals and organizations, as well as some of the requirements we have around staff data. So collecting this type of information from staff, trying to look at employee opinion surveys, stratified if you can by the different sociodemographic characteristics of your staff. So the elements of the certification program that are around internal efforts around diversity, equity, inclusion may also be a bit of a time limitation for some organizations, depending on how much they've been doing in that area so far.
Thank you. And here's both a comment and a question. So compliment, thanks for such a great presentation. this person is asking if you have any experience using area deprivation index to explore opportunities to address health equity.
So one of the things in the certification program, we have a requirement around looking at community level data, and it can be any community level data. So organizations are using census tract data, they're looking at other data sets that are available, government public health data sets, or they may be using their community health needs assessment information. So there's a number of different ways. So I haven't used that type of data just at the Joint Commission, but I think there's a number of different ways organizations can use available and existing data sets to learn a little bit more about their community and their surrounding area, to identify if there's services and revisions to services that they need to put in place just at the sort of population level versus addressing specific issues that are coming through the health-related social needs data that they're collecting as well. But the Resource Center is really where, I'm not sure if we have anything on there about the specific question, but that's where we're trying to get examples from organizations that are using different tools that are out there, using different data sets, trying to identify needs in different ways. And the idea with the Certification Resource Center is that we'll have areas that, again, you can click on the different domains within the program, takes you to a section of resources that are specific to that issue. And then we're also going to have, I believe they're calling them spotlights, where they have, again, some short video interviews with organizations that are leading in the field to talk about some of the challenges that they've faced in different ways that they've, different examples of what they've implemented and what's worked and what didn't work. So there's a great opportunity within those videos and vignettes for organizations to share the tools that they've used and share some of the challenges that I know many organizations are facing.
Wonderful. And I know earlier in the presentation you were sharing, that there's a step of collecting the unmet, the health-related unmet social needs, but also that next step in being able to provide resources, for those individuals in the hospital setting. Do you have any recommendations or examples of how hospitals have built relationships with those community organizations, those resources, on the other end, once individuals leave the hospital?
Sure. Well, there's some, so on the website, on the Resource Center, we have a couple of examples, and then within the certification program, because we have specific requirements around collaboration, so there's a few more resources there that are a little bit more specific to kind of forging that relationship and establishing those connections with the community. But some organizations are using, these larger databases to, identify resources in the community, and then they can link that to give their patients some information about the nearest food banks, for example, or different shelters that may be available. And so some of that is sort of database driven. Some organizations have had long-standing relationships with communities. I think case managers, social work, a lot of those inroads have already been met, I think, or been set up. I think it's really more of making sure that you have all of the right people at the table as you're having these conversations about how you can take advantage of connections that you already have within the community and make sure that that information is getting to patients that have unmet needs in that area, and then try to make sure that you can refer patients out to those services, and then also work with those organizations, those external organizations, to make sure that that referral process is working, that is smooth, or if there's opportunities to get feedback about how patients are using those services or things like that. So I think part of our certification requirements is to really look at that relationship that organizations have externally and how they're looking for opportunities to improve that and make it more efficient.
And Renee, just to add on that point, in terms of get with the guidelines data collection, maybe during your stroke abstraction, you don't typically read the case manager's note. You didn't realize that maybe there is a social needs assessment documented within that note, that now you'd be able to connect the dots with get with the guidelines and connect that information there. So that's where we want to, really be able to provide a general framework, knowing that every hospital is different. Maybe your hospital, the EHR isn't even set up to collect gender identity elements just yet, but when it is, you'll be able to tie that into your get with the guidelines information.
Thanks, Jessica. And I think we have time for probably two more questions. There was a question talking about social isolation. I think many of us have started to see in the research just more evidence looking at social isolation and the impact on health. Dr. Cordero, I can't remember if you mentioned this earlier on in the criteria, but is that something that Joint Commission is looking at? Is that something you're hearing from any of the hospitals that you interact with?
We haven't included it in the list of the health-related social needs as just examples, but the list that we provided are just examples. So organizations, if they feel that that's something that they want to start to look at and start to include in assessments, then that's, that would be fantastic for them to include that, and then they can talk to your surveyor about what you're learning. We're, again, continuing to monitor the field and literature to see if there are other examples, other health-related social needs that organizations are collecting, new things that people need to consider, and the idea is to continue to post that information on the Resource Center as kind of a living, breathing website to, not just address the things that we've always addressed, but also to include new areas that organizations may consider just to continue to address the varying needs of their patients.
Great, thank you. So this next question is, Jessica, I think you can answer this one. This individual is saying that they currently collect the social determinants of health, the health-related social needs, but only in Get With the Guidelines stroke and Get With the Guidelines heart failure. Is this collection available for the entire population of patients? So I think, Jessica, you can speak to that for Get With the Guidelines, and then Dr. Cordero, if you could touch on the population that's included.
So I think if I understand this question correctly, it sounds like your institution is collecting social determinant of health information. Perhaps you're doing a standardized social needs assessment, but maybe you're only capturing it right now if the patient has a stroke or heart failure or meets the criteria for those registries. So that may be something to think about internally. Is there a way to look at that data more globally within your organization? But if you're capturing that and Get With the Guidelines, you could at least run those reports to get a glimpse of, okay, at least in our stroke population or at least in our heart failure population, these are the social needs that we're seeing. I hope I answered that correctly. But it is also available in our other registries as well. But if those are the only two that you're using, you may only have access to those reports through Get With the Guidelines in those registries.
But the only thing I would add there is that, again, right now, there's so much flexibility built into these requirements that for element of performance 2, which is the assessing health-related social needs, organizations can identify specific patient populations that they want to focus on. So it can be, you're just looking at heart failure patients, you're just looking at stroke patients at this time, and that would be in compliance within the standard. It fits within what our intent is of that element of performance. I think as you potentially move towards certification, or as we continue to evolve these requirements over time, the idea is to start to collect health-related social needs from larger populations within your organization, or again, for certification, it would be all patients. And so I think starting out with a certain area, getting your organization to get used to collecting that type of information, building the infrastructure to handle those data elements, to be able to use those for analysis later, I think would be a good start in one area. And again, that's why we built that flexibility in, because we know some organizations have these areas within the organization or populations that they've been collecting this information on, and it'll allow them to learn about disparities, include some interventions at that time, and then hopefully scale up those efforts across the organization.
Thank you, Dr. Cordero, and thank you, Jessica, for answering those questions. Jessica, I will turn it back to you to wrap things up.
Great, thank you so much. So I'd like to thank Dr. Cordero for leading today's webinar. Thank you for your participation in today's event. After today's webinar, you will receive a follow-up email with a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. In that email, you will also receive a link to view a recording of today's presentation. On behalf of the American Heart Association and our presenter, thank you for joining us and have a great day. This concludes today's presentation.